We're very excited to have you on this 10th iteration of our webinars that are focused on peer-to-peer learning and making sure that we can learn from each other and from the global level evidence. And I am extremely excited and privileged to introduce Kara Hanson, who is going to be our chair for today's webinar. I don't think, Kara, that you need much of an introduction, but I will nevertheless say that you are Professor of Health Economics at the London School of Hygiene and Tropical Medicine, that you have more than 30 years of experience in researching economics in low and middle income countries, that you're president of AHIA, director of the NIHR Global Health Research Program, amongst many other things. Kara, over to you.
Thank you very much, Nouria, and it is indeed a huge pleasure to be here with this group today. So I think the main reason why I get to chair today is because I chaired the Lancet Global Health Commission on Financing Primary Healthcare, to which a number of our speakers today contributed. And one of the key central message that came out from the commission was the need for countries to spend more and spend better on primary health care. And one of the features of primary health care spending in many countries that was identified in the Commission was the fragmentation of funding for primary health care. And Agnes, who's our first speaker, will describe a little bit in more detail what we mean by fragmentation and some of the consequences of fragmentation, and then introduce the discussion about what countries can do to reduce fragmentation. Now, that report was published 3 years ago, and it does feel some days that we're in a very different world from where we were 3 years ago. So the current context is one of considerable turmoil in global health and global development. And that's largely because of the very sudden reductions in development assistance, initially by the US, but then followed also by other countries as some of the consequences of kind of changed geopolitics have become clear. Those cuts in development assistance are having an enormous and very negative impact in some aid-dependent countries. But they're also providing a challenge to countries that are less aid dependent or not aid dependent, and I think also providing us an opportunity, a moment of to catalyze some changes that were perhaps long overdue and that we wouldn't have made so suddenly, but we're in a position now where we need to reconsider these spending arrangements for primary health care. So one of the opportunities is to, first of all, recognize that a lot of development assistance and bilateral assistance was very inefficient. So it was not achieving all of the health benefits that it could, or another way of thinking about that is that those benefits were more costly in financial terms than they needed to have been. So this kind of change in the health financing landscape gives us a fantastic opportunity to look at how we structure things differently in the future to be able to generate health benefits and health impacts at a lower level of resourcing. But I think also there's a very important cautionary note here as well, which is to be sure that the response to these changes in development assistance and into health financing in general, that the response doesn't contribute to further fragmentation. So that is just by means of setting the scene for the discussion and the challenge that faces us, but also the opportunity to share country experiences and share lessons about what does seem to work as some principles for reducing fragmentation in primary healthcare financing. So we're going to start today with a presentation from a paper that was published in the BMJ Global Health in January of this year. The lead author of the paper, Agnes Munua, is here to present the paper and talk about some of the principles and definitions of what we mean by fragmentation, some of the consequences as well. Following that, we'll move into a panel discussion featuring 3 countries that feature in the paper itself and some of the the approaches that have been taken to reduce the effects of fragmentation. And that panel will be chaired by Cheryl Cashin. And then we'll have a good period of question and answer. So you can ask questions about the general framing of the issue, or ask questions indeed of the individual country presenters. And then we're going to wrap up and summarize with some wise thoughts from Susan Sparks from WHO, a health financing expert there. So we have a really good lineup, and I think this is going to be a very stimulating hour and a half. So let me begin then by inviting Agnes Nouria to take the floor. Agnes is a health financing expert. She is working as a program director at Results for Development in Kenya, and she is going to open the discussion by framing the issue and giving us some common language around this issue. So Agnes, over to you.
Thank you very much, Cara. And I must say it's a distinct honor and pleasure to be providing an overview of the paper on behalf of all the co-authors you'll be hearing from in this session. So I'll start with just giving an overview, the motivation behind the paper. And Cara has already highlighted why fragmentation is a consequential issue when linked to the Lancet Commission findings. But I want to start by taking a step back to describe what we mean by fragmentation to ensure we're all on the same page. So we looked into the literature on fragmentation to understand how it has been framed, and we thought that the descriptions by Bossat et al. And Kanta et al. Are the most relevant. I'm very pleased to see Thomas Bossat is actually one of the attendees at this webinar. And so for the purpose of the paper, fragmentation is the existence of a large number of pools or separate funding mechanisms, and it becomes a problem where there is lack of an explicit means of coordination. And the coordination part is very important because there are contexts that have been able to use complex information systems to improve the coordination between the different pools and fund channels. But these are lacking in many low and middle income countries like mine in Kenya. And so we see a problem when these separate pools and funding mechanisms are channeled to providers with different rules for how the funds are used, creating confusion in how to use these funds amongst the providers. And so the objective of the paper was to really look at how the purchasing function can be used to alleviate some of the challenges created by multiple fragmented schemes and to address the negative consequences of fragmentation at a system level. So on the next slide, we started by first exploring what are the drivers of primary healthcare financing fragmentation. What are the issues that lead to fragmentation? And came up with 3 key areas, which I hope to resonate with all of them, as they do my kind. So one, low public spending. We picked up again in the Lancet Global Health Commission that and the UHC monitoring reports that have shown that public spending is off target to reach universal health coverage and to provide high quality primary healthcare services. And this is a problem because where there's low public spending, then health users rely on out-of-pocket spending, worsening financial protection, and also increases the chances of them foregoing care and worsening health outcomes. Now, because of the low public spending, we do look towards alternative sources of health spending, and one that are sought is the channel through donor funding for primary healthcare services, which is critical for priority health interventions such as family planning, immunization, HIV, TB, and malaria. But when these are delivered through parallel programs, they do fragment the system. And yet another alternative source that we've seen is the creation of new schemes. So not just about donor-funded programs, but really schemes that are created commonly to mitigate the low public spending and raise alternative revenue, such as social health insurance. But we know the ability of these social health insurance schemes, national health insurance schemes, to raise additional revenue has been quite low in countries with a large informal economy, again, like my country, Kenya. In addition, new programs such as performance-based financing schemes, voucher schemes, or CBHI programs that have been introduced well-meaningly to increase coverage are also seen as an alternative source of health, particularly for primary health care. But again, when these schemes are not set up with a plan to expand the whole population, they end up worsening fragmentation and creating a patchwork of coverage of different benefit packages, which may worsen equity and with mixed rules and incentives for providers that do not promote the efficiency of the health system. So really, as we thought through these drivers, we thought, okay, so thinking of the health provider level, the primary health provider level, what's the impact there? And so we developed this hypothesis to explain what these multiple schemes and multiple funding channels with different rules for using these funds at the provider level cause at the facility level. And we refer to this as the downward spiral because really things just continue getting worse and worse. And so first, the multiple schemes create duplicated transaction costs, administration systems, because they are, and with different spending rules, they do create conflicting signals to providers. So really just think about a provider receiving different streams of funding. One stream of funds says you can spend on incentives to health workers and medicines, but the other stream says you can only spend X proportion on medicines and another X proportion on operation and maintenance. And then not only do they have rules on how they can use the money, but they must use very specific formats or platforms, sometimes different, to account for these funds, and a different one for the other stream of funds. And all these rules can create confusion for providers, and unfortunately the repercussions for misallocating or even worse, misusing the funds can result in an inertia of these primary healthcare providers who are not sure of what to spend, how to spend, and realizing at the end of the year they have unspent funds, which of course is an inefficiency in itself. And so because these different streams of funds do not harmonize or coordinate the different inputs being paid, there's higher risk of misallocation of funds, as some inputs have more funds and others have none. And really think of the analogy here of having money to pay for the telephone, mobile phone airtime and internet costs, no money to pay the electricity bills that run laboratory equipment or an incubator, if there's one, which come to mind. And in all these issues, it leads to a situation where the provider is not able to deliver good quality primary healthcare services, which undermines the trust in primary healthcare overall among the community that they serve. And so this reduces utilization at the primary healthcare level and enhances the need for communities to bypass primary healthcare to seek care at higher levels of the system that are ultimately more expensive. And again, this is not efficient. And so once we had, explored the drivers, and we had also looked at possible consequences of fragmentation at the provider level, we looked at, or we sought to understand, are there certain country experiences that have alleviated some of these consequences of fragmentation? And so these are the experiences we profile in the paper, and you will hear more in the panel from Argentina, Indonesia, and Tanzania. But in brief, we share in the paper how Indonesia, on the initiation of the insurance program JKN, chose to merge the different schemes in existence into one scheme and provide the most generous benefit package among the schemes, one to reduce resistance, but also to improve equity in access to services. And in Burkina Faso, though we don't hear from them today, in the paper you'll read about how they resisted worsening fragmentation by avoiding a new scheme and merging channels of funds into a publicly funded program known as Gratuite, which has brought a lot of benefit to mothers and children and improvement in their health indicators. And then crossing to Argentina, we share how they have harmonized purchasing functions in Program Asumar through performance-based transfers from the federal to the subnational level, and also uses mechanisms to increase coverage over time to cover the whole population without formal health insurance. And our final example really speaks to how they have streamlined funds to providers, the primary care providers, by creating a basket fund where multiple streams of funds from various sources are channeled primary health providers with the same rules for the use of these funds, and also increasing the amount of funds that flow to primary healthcare level overall. And I hope you really enjoy hearing these first-hand accounts from the panelists. And so in conclusion, in my next slide, I just want to share some of the key messages from the paper, which are very intuitive. I do hope you get to read all of it, but in summary, we say that of course, the first step is to reduce the pools if possible, right? This is most natural. And we provide ideas on how to use purchasing to address fragmentation, which is really the premise of the paper. And so we start by saying, first, avoid adding new schemes, worsen fragmentation, build on what exists, and avoid bypassing systems. And then we know that fragmentation can be a very political topic, especially if these schemes already exist. And there's need to apply political economy analysis and frameworks to understand the dynamics and where the opportunities are to address fragmentation. And just to say that this was very important for Burkina Faso as they were aligning stakeholders behind the vision for Gratuite. And when reducing the number of pools is not feasible, we suggest looking at the purchasing function and addressing, for example, the benefit packages to reduce the differences among different population groups and improving equitable access, harmonizing the provider payments so that providers are not incentivized to treat some groups' generous packages better than others who don't, and using information systems to continue to continuously improve the purchasing functions overall and addressing some of the inefficiencies that may exist. And finally, we suggest that you might need to take an incremental approach. And the Argentina example is really illustrating this, how they started with a small pool of funds that was only 1% of the entire health budget. And they use this to test a new modality to create incentives at the subnational level, performance-based incentives, and with the existing PFM systems to catalyze changes that build over time and over 20 years has expanded to much more of the population. And so we hope you take a moment to read the paper, and I look forward to responding to any questions you might have in the Q&A session later on, and that you enjoy the experiences that are shared in the panel. Thank you, and over to you, Cara.
Agnes, thank you very much for an extremely clear presentation of the paper. And as Agnes says, the paper has a lot more detail. It spells out some of these arguments, and we would urge you to click on it. It's open access. The link has been put into the chat. So now we get to move on to the next stage, which is a panel discussion where our facilitator, Cheryl Cashin, who is Managing Director of R4D with responsibility for the strategic and technical oversight of about half of R4D's portfolio. She is going to be facilitating a discussion with 3 country experts. And let me just also introduce then our discussants. So we have Gamini Mtai, who is a health economist and is the country director for R4D in Tanzania. Welcome, Gamini, nice to see you. We have Martin Sabinoso. Martin is now working as a consultant on health reforms and health financing, but he was previously Deputy Minister at the National Ministry of Health in Argentina, and he was also the former executive director of Program Sumar, which is one of the examples that he's going to be sharing of an approach to reducing the effects of fragmentation in a health financing system. So welcome, Martin, lovely to see you too. And we have Dr. Prastuti Sowondo, who's known to all of us as Ibu Beki. Ibu Beki is Senior Advisor to the Minister for Health in Indonesia. She is also a lecturer at the Faculty of Public Health at the University of Indonesia. So great to have you with us as well, Ibu Beki. So Cheryl, with that, I will hand over to you to lead us through the next part of the program.
Thank you so much, Cara, and good morning, good afternoon, good evening to everyone. What a delight to be here with this panel of experts who have contributed so much globally in this space, but have also such deep experience leading some of the initiatives that we're going to be discussing today in their countries. So this is going to be really an opportunity for us to think about and examine what was done in these 3 country examples in Indonesia, Argentina, and Tanzania to take steps to reduce fragmentation in primary healthcare financing. But more importantly, we have the chance to dig into the how and really that how-to, because we know that reducing fragmentation means changing how funds flow through the system and changing maybe who gets to decide how the funds are used. So as Agnes highlighted, this is not just a technical challenge. This is a highly political challenge with a lot of political economy issues that also need to be navigated. And we have some great examples here of strategies that were used in these countries to make progress in spite of some of those challenges. So I want to get right to the panel discussion, and I'm going to just start out by asking a question to each of the panelists that I think gets at the heart of one of the main lessons from this experience. But then we're going to have more of a conversation and really try to draw out some learnings on the how-to on this. So Ibu Beki, if I could turn to you first. We know that Indonesia has been one of the few countries that has been able to successfully address fragmentation by merging multiple schemes at the national level. That really kind of highly challenging option that Agnes mentioned that isn't always available to others, but you've managed to do that under JKN. And so I would like to ask you to share a little bit about what made that politically feasible at that moment in Indonesia to merge these schemes, to have that higher level approach to defragmentation. And then what did you do? What were the steps taken to make it possible to agree on a unified set of purchasing functions, the benefits package, the contracting arrangements, provider payment methods, and rates. So I think there's a lot for us to learn in your experience. So over to you.
Yeah, thank you, Sarah. From Indonesia, I think prior to 2014, we have more than 400 insurance schemes. We have employee schemes, the poor, and then civil servant schemes, and then local schemes. As you know, Indonesia is under highly decentralization, and local leaders want to have their own schemes, but what happened is just like Agnes already described very well, is the benefit package varies from one to the other. Small scale of funds, pool funds, risk sharing is not working efficiently. Accountability is an issue, and bankrupt here, they don't have sufficient funds and everything. So we are lucky that in the 2004 there is a law to establish the social health insurance, but nothing happened afterwards. After we know all the chaos of fragmentation in the health insurance, then many academic and government bureaucrats thinking how we can make it better. So there is a political will at that time, and we are lucky that we can consolidate it, all the scheme into one. The challenge, the hardest discussion at that time is the benefit package. Which benefit package that we want to use? Because there is a scheme that only offer inpatient. There is a scheme only offer outpatient. There is a scheme that offer comprehensive one. So we are discussing, and at that time, because the time is short and we really want to use our political windows very efficiently, effectively. So what we did is, we don't have time to prepare all this actuarial-based calculation, documentation, sophisticated technical academic calculation. But we said that we choose the modest one, not comprehensive. But when we presented to the parliament said, why we have to reduce to why we are not picking the comprehensive one. So there is a lot of debates back and forth with the parliament, and they still want to the comprehensive one. And finally, we choose single payers with a very comprehensive benefit package without back up with the proper actuarial calculation. But the political will is there, so we just use that opportunity. Thank you, Sarah.
Thank you so much, Ibu Becky. I think this is a really important lesson about when you're faced with those politics, that kind of going to the highest common denominator instead of the lowest common denominator with your benefits commitment. But then we can talk later about how you use strategic purchasing levers to try to make that affordable after making that political decision to make the consolidation possible. So thank you so much for that, and we'll come back to you. But Martin, just turning now to Argentina, we know from the experience of Programa Sumar that you've been able to reduce some of the elements, the effects and consequences of fragmentation with a very small amount of funding in a very highly decentralized setting. So if you could just share a little bit more about what some of the key tools have been that you've used and how you've managed to implement those tools in such a highly decentralized setting to get the impressive results that you have.
Yes, sure, Cheryl, thanks for this opportunity. Well, as you may know, Argentina is a federal country, and it has a highly decentralized health system. So since 2004, and with less than 1% of government's public budget for health, the National Ministry of Health has been implementing, through Programa Sumar, transparent and predictable conditional transfers linked to results. in order to increase the effective coverage of a relatively small benefit package for the population that has public health coverage, around 21 million people today. So the program's allocation criteria combine equity measures, people without formal health insurance or life expectancy, and also performance measures, mainly health outputs. I would like to emphasize that the program also defines the explicit condition that the funds can only be used to purchase the program's benefit package from public facilities, and that public facilities have autonomy to allocate transfer funds to provide those benefits. Provinces must also co-finance Programa Sumar by providing 15% of the amount provided by the national government. And although the source of funds was a new funding source, injecting additional resources to the public health system, and that a separate project management unit was created, the funds are channeled through the government's financial system. And in terms of how, it is important to bear in mind that Programa Sumar was designed in close consultation with the provinces, which ensured its feasibility and adaptability across diverse local contexts. The implementation of Programa Sumar has been an iterative process as well, entailing gradual expansion, continual fine-tuning, and careful coordination across levels of government. It also took an incremental approach to expansion in terms of regions, populations, services, provincial co-financing responsibilities, and management capacities as well. So this sequenced progress allowed implementers to learn from experience, to adapt the strategy to the changing context, and give the system something very important, enough time to digest the proposed changes. So the program's principle of defining some core rules at the national level, such as the benefit package with strong focus on PHC, the output-based payment mechanisms or data requirements, while providing provinces with flexibility and autonomy to use their own information systems or to decide the final allocation of the transfer funds at the facility level, has enabled the national government to align actions nationwide while managing provincial diversity effectively. So to sum up, I would say that the program is articulated around two strategic pillars aimed at defragmenting the public health system. The first pillar seeks to establish a shared agenda between the federal government and provincial authorities to elevate and consolidate the PHC financing strategy across all jurisdictions. And the second pillar focuses on strengthening the strategic purchasing capabilities and instruments of provincial ministries of health, enabling them to align actions with municipalities, with PHC facilities, with healthcare payers or social insurances, and across provinces as well. So thereby, the program fosters greater coherence and coordination within the health system. Over to you.
Thank you so much, Martin. I always learn something new every time I hear you describe this program. I think just to highlight what I'm hearing about in terms of the political economy of reducing fragmentation, it seems important that these were additional funds, maybe even a small amount, but it didn't, it reduced a little bit of the trade-offs that we often talk about in this space. And I heard about also balancing some consistency and harmonization of approaches with flexibility to be adapted to the local needs. So getting that right, where do we need consistency? Where do we need flexibility? I think we can come back and get some more discussion around that. And then finally, this attention to capacity building and time to let the changes be absorbed and to have that capacity be built. I think that's another really important practical lesson. And I think will also resonate when we turn to Gemini about the experience in Tanzania. And Gemini, I think this is a really important experience to share because what we heard from Ibu Becky and Martin were some policy windows and initiatives that started at the national level and with great collaboration with subnational levels were able to make change. And I see the direct facility financing experience that you'll share in Tanzania is really having the provider level be the main lens. So I think that will be a really interesting perspective to hear from you. But it's also a case where in Tanzania you have addressed harmonization and defragmentation at really both levels, at the level of bringing funders together in one basket, and then also having the providers experience one flow of funds. So can you share a little bit about how that happened at both levels, and what are some of the systems and capacities that have made it possible to be successful? Over to you, Gemini.
Okay, thanks, Cheryl. So as we might all know that Tanzania is following a decentralized policy, and at the beginning of the policy itself, the way the budget and planning processes together with the fund flow was designed, budget funds were coming from the central Ministry of Finance to the local government authorities like the districts, but also we have the health insurance system as well with the National Health Insurance Fund and the Community Health Fund. And the decentralization, the reimbursement from health insurance are also flowing to the local government authorities like the districts. And then later with the reduction of user fee in the L90s or mid-90s, facilities were collecting user fee, but also the funds were also deposited to the districts. So at this point, the facility operation were mainly based on an in-kind. So councils or districts authorities were responsible to procure everything and provide the supplies in kind to the facilities. But also within the central budget system, we have the Health Basket Fund, which was a result of the sector-wide approach in L2000. And in here, this was the modality of harmonizing the partners or donors who have the interest in health sector to have a collective pool that is managed at the central level. So prior to 2015, also the Health Basket Fund resources were also flowing directly to the district authorities. There were a couple of challenges that we observed in that case in terms of service delivery. One of that was timely delivery of the inputs that are required to deliver services, but also the funds that were flowing to the councils were also coming up with different regulations, like the Health Basket Fund had its own rules. There were conditions in terms of how to use the Community Health Fund, but also the National Health Insurance Fund. So it was a challenge. So that's where the challenge with the fragmentation was realized. But from 2015, the discussions that were mainly facilitated through the Ministry of Health in collaboration with the Ministry of Local Government, but also with a huge engagement of the development partners to see how the system can be improved and the fund flow can also be improved to have the visibility of the service providers, but also to make sure that the funds that are coming from these different pockets are better aligned at the point of service delivery. So the decision was made, and this was really facilitated with the engagement with the Ministry of Finance to say, okay, with the Health Basket Fund that's coming through the treasury system, instead of flowing to the councils, let's redirect these resources directly to the facilities. And at the same time, the decision was also made for the health insurance reimbursement, the facilities also to retain the money that's coming from the health insurance pocket. And also they were given the mandate to retain the user fee. So that's one of the aspects of the reduction in fragmentation, in changing the modality of the flow of resources so that we have all the resources flowing to the facility bank account. But the other part that was very important, which is currently also ongoing, is on the harmonization of spending guidelines. Because if you have like a fragmented management of resources and the guidelines, it's another challenge that is imposed to the facilities. But now we have the same planning and budgeting guidelines that applies across all the fund sources that are flowing to the facility bank account. And then we have also the same financial management systems that is used to manage all the pools, all the fund flows that are coming from the different pools. And to be able to implement this kind of initiative, we need to have a high level of alignment between the public financial management rules and regulations, together with the health financing system regulations as well. And for the Ministry of Finance, for whatever the money that's flowing to a public entity, it has to follow rules and regulations. And at the facility level, because the facilities were not there, were not visible within the PFM system, it was a challenge for the Minister of Finance to allow the flow of money from the treasury system to the facility bank account. So how this was implemented was first is to improve the PFM system, to make sure that we have the visibility of the frontline service providers as a public entity that can receive money and also can manage and use money with their own decision. So there was a change within the chart of account so that we have the service providers codes within the system so that it can also be able to receive ceilings and also develop plans and budget. But also the facilities had to open up the bank accounts, like to have a standard bank account across all the facilities so that there can be like effective management of the resources that are flowing into the frontline service providers. But the other important aspect is the introduction or extension of the PFM systems to the facility level. The first system was related to planning and budgeting, because all the public resources in Tanzania, before you can use them, they have to be appropriated with approval within the parliament. So we need to have a planning and budgeting system that is facilitating the use of the resources. So this planning and budgeting system were extended to the frontline service provider. But also there was an introduction of the facility financial accounting and reporting system. This is a financial management system for all public facilities and also the schools, both primary and secondary. They're using the standard financial management system. The extension of these two systems were very important because the Minister of Finance, what the minister cares is to make sure they have a mechanism of consolidating the financial reports within the system. So they need to be able to see the information on planning and budgeting, but also the expenditure for each of the entities that is receiving public money. So this was also an enabler that also convinced the Minister of Finance that we are able to implement and harmonize the flow of funds to the frontline service providers. At the same time, they're sure that there's going to be prudency in the use of the resources that are flowing to the frontline service providers. So ideally, those were the factors that helped to facilitate this harmonization of the funds. But the other important aspect that facilitated the reduction in fragmentation is the harmonization of the modality in terms of how you are determining the resources flow to the facility bank account. Tanzania has adopted like a standardized capitation formula that is being used across all facilities to disburse the house basket funds that are coming through the treasury system. And that standard capitation formula has been adapted to the disbursement of the community health fund. And currently there are already ongoing discussions also within the National Health Insurance of trying to adapt a capitation formula that will also be used to disburse the resources to the facilities. So as to summarize that, there are different aspects of targeting and addressing fragmentation in Tanzania. So through the harmonization of the formula in terms of the resource flow, harmonization of the financial management systems and planning guidelines, and the standard management of all the resources at the facility bank account. Yeah, thanks.
Thank you so much, Gemini. I think what I'm taking away from what you just shared, we often think about fragmentation really starting with multiple sources of funding and then having that pass all the way through down to the providers. But if the rules are clear and standardized, then that multiple sources of financing isn't the problem. It's getting those rules standardized, and that has to engage the public financial management system. And so having that set of rules and having that one flow actually show up in the bank account of the providers and having the rules, standard rules about what they can do with those funds sounds like a really important lesson here. And that also, I think, resonates with what I've heard from Argentina and Programa Sumar, that what actually happens when the funds arrive at the facility level, how can they be used? And maybe we'll talk about this as a next round of questions for you all, sharing Agnes's presentation, that sort of vicious cycle that can happen when the consequences of fragmentation persist, and how to really change what happens at the provider level. What is their experience and how does that improve when the consequences of fragmentation are addressed. And I know this is a long journey. It doesn't happen overnight. And so maybe just to hear from each of you, what are you seeing changing at the provider level that might demonstrate that they have the ability to use resources a bit more effectively, and what challenges still remain? I'm sure this is still an unfinished agenda to a certain extent in each of the countries. Would anyone like to jump in first, or I can call on one of you? Ibu Becky, your mic is off, so maybe I'll ask you to jump in.
Thank you, Cheryl. Yeah. So when we started in 2014, I think we know that we collect funds from the contributions. So the contributions is based on it's a mandatory, but we know that in stages. So the contributions is collected from the employees as a percentage of salaries, sharing between employer and employees. And for non-employed, we pay fixed amount, and then there is also a fixed amount paid by the government, both central and subnational paying government. So the money, the funds that is collected when we started is only like 60 trillion. It's about maybe it's, I don't know in dollars, but I think after 11 years implementation, the amount that was managed by the JKN is about 3 times, 3 times higher. Yes, most of the money, I think, like Cyril just said, that this social health insurance agencies trying to do contract with the providers with with a standard that they have to offer, and then the payment system that we use is a prospective payment systems with the DRGs in the hospital and adjusted capitation for the primary care. And I think providers with large additional funding managed by the social health insurance agencies, the providers are happy because there is a guarantee that they receive payment. Even the tariff may not be sufficient, but it's guarantee, compared to previously, because on the previous schemes, some of the local schemes do not pay, or delay the payment. But with the social health insurance, there are some security that they can pay the providers. So providers is actually having additional cash flow into the systems, and many of the hospital especially expand. What is the challenge? The challenge is from when we start the implementation of social health insurance in 2014, the proportion of resources going to primary care is about 18%. But as you as the years goes, now the proportion become less and less. One of the problems is because we are not adjusting the amount of capitation quite quick, so what, and we aware on that. So our challenge now is we want to balance the spending between hospital and primary care. And I think that is also one of the agenda in the healthcare reforms that we are working now. I think that's enough, Cheryl. Thank you.
Thank you, Ibu Becky. I really appreciate your last point. One of the benefits of having a defragmented system is you have more policy options, and you can look at the whole and see the share going to primary healthcare, and you can make a policy action to change that. And especially with a capitation payment system, you can actually look at the total amount and manage that by the capitated rate. So I think that's an important benefit that you've highlighted of reducing fragmentation at the system level. Maybe Martin, I'll turn to you. What's the situation for providers now in Argentina? What's the unfinished agenda?
Thanks, Cheryl. Well, let me say that we all know that with these financing mechanisms that could become very powerful tools to develop a concerted agenda with provinces, to equalize resources, to inject additional resources at provinces or at the facility level, to give health providers for the first time autonomy to allocate these resources in order to improve their effective coverage. Well, this is true, but we must acknowledge that additional resources or more autonomy can help us to achieve better results. We need a more comprehensive approach. Autonomy is not an end in itself. Of course, providers should be accountable for the funds they allocate, but more importantly, for the results they achieve. But granting decisional rights, placing additional resources at the facility level, does not ensure per se good decisions. For making good decisions at the facility level, they need results orientation, they need actionable information, they need management tools, they need to develop new managerial skills, they need permanent supervision and close support. So we learned that empowering facilities does not mean leaving them alone and does not eliminate the responsibility of the central level to control and accompany them. And we also learned that this autonomy without strategic guidance can bring more fragmentation, more inefficiencies, more inequities, and more disconnection between actors. And we are always facing this great challenge, a disconnection between policies and providers. But I was referring, they also need to be equipped with strategic information, with actionable information. So here we can distinguish a very concrete contribution of Programa Sumar, because in its 20 years of implementation, the program nominally registered the entire population covered by the public health system, and this served as the main driver of digitalization for health service utilization data. So in this way, and bearing in mind the final outcome, the final goal of defragmenting the system, that is creating a more proactive and a more people-centered approach within the PHC network. Well, I would say that this contribution, it enables the systematic monitoring of the population's effective access to the benefit package that is financed with additional resources from Programa Sumar. And this data digitalization also supports the development of a very proactive healthcare approach within a people-centered care model. Over to you.
Thank you, Martin, and thank you for bringing us back to always, what are our objectives? That we're not looking to reduce fragmentation for its own sake or to take any of these steps for its own sake. It's all in service of having a more people-centered, responsive primary healthcare system that gets better outcomes. And that we observe that when the rigidities are reduced and the funding flows are harmonized, there's more opportunity for providers to allocate those resources in the best way to serve their populations. But in order to do that, they need autonomy. And we're hearing that from all of you. But again, autonomy isn't for its own sake, that's also in service of better resource use. And we also need those accountability measures. And I think that echoes very closely with what we heard from the Tanzania experience and all of the efforts in place to put those accountability measures there. And what I heard from you, Gemini, is that then also reinforces the donor's willingness to put their money through the government system and to put it into a basket. So all of this now turning into a virtuous cycle instead of a vicious one. Now, Gemini, back to you for just the unfinished agenda in Tanzania.
Okay, thanks, Cheryl. So first, in terms of what are the benefits of this alignment and reduction in fragmentation, the studies that are coming out, you see there is a positive impact to the facilities, like the degree of drugs stock out, the complaints related to that are really coming down, but also the community participation in the accountability and delivery of services is also increasing. Like in Tanzania, we have the health facility governing committees who have foreseen management of service delivery to the facilities. These committees, initially they were ineffective because there were no resources that they could manage at that point. So at this point, at least, they're able to sit with the facility staff, sit together to prioritize service delivery. So there's a positive impact on that space as well. But also with this alignment or harmonization of fund flow, we see there's a strengthened role of the council and districts in terms of governing service delivery. So there is an automatic separation between the purchaser as a provider, a provider at that level, and the managers of service delivery. Initially, the districts were playing both roles, but at this point, they have more power to manage service delivery at the facility level. What is remaining to be addressed, we still need to work on the side of more alignment of the PFM side, especially on the space of budget execution. I think that's the area that still need to be addressed. Timely disbursement of funds. There's still some delays in the disbursement of, for example, the funds from the Ministry of Finance, but also insurance reimbursements. They're also an opportunity for improvement in terms of the reimbursement to the facilities. But also we still need to work on the side of somehow reducing the bureaucracy in the access to the resources, like the levels of approvals from the facilities to the districts. There is also a room for improvement on that in that space. So ideally, if we have the facility governing committees, there are some of the aspects of spending that can be autonomously decided at the facility level. So there is a room of improvement on that. But also the commitment to disburse based on what has been committed during the planning and budgeting. So what comes to the facility level is still not to the level that has been committed. So, but also in terms of simplifying the procurement processes and regulation as well. So there's some space to improve on the side on how we can really move to another level of provider autonomy and give really the space for the facilities to improve, but also continuous support on the capacity building at the facility level. So yes, we have the financial management systems and planning and budgeting guidelines at that level. Still, we need to continue investing on the capacity of the facilities to develop good plans and budgets, especially at this point where we have, for example, we don't have a flexible review of reallocation of plans and budgets. We only do it once in a bit year. So you really need to support the facilities to develop plans and budgets that really address the needs of the population. But in the longer term, I think we need to also look through within the planning and budgeting system, at least to start thinking in terms of not managing the plans and budgets through the line item budgeting process, but rather move to a more flexible output-based planning and budgeting system that will introduce flexibility at the provider level to do a better job in terms of reacting to changes in health needs at that level. Yeah, thanks, Sharon.
Thank you, Gemini. I really like your point that this is not just about reducing fragmentation. It's a broader picture of how funds flow to primary healthcare and having them flow in a more harmonized and less rigid way. But there are many other dimensions to that, the rules and the budget execution, and looking at this holistically for how making funds flow more efficiently to be able to be used more efficiently to meet the needs of the population, and then also to have that accountability. So I think that's a great point. I'm going to maybe just do a couple of highlights that I would like to draw attention to before we turn to the question and answer session. Thank you so much. You all contributed so much rich depth to the how-to of the experience that you shared in the paper, and maybe just a couple of reflections on how to navigate this reducing fragmentation in the service of better allocation and use of resources for PHC, that there needs to be a political window or a political opportunity, and how that happens and how to harness that. And you can't wait until all the analysis is done and everything is perfectly set up, but start with that window and make the case and get off on a good foot, but then incrementally improve. And all of the stakeholders that need to be engaged to navigate that process. We heard Parliament, we heard Ministry of Finance, we heard local governments and community health committees, so that broad engagement on the agenda. Having additive funds where possible helps smooth the political economy of changing the flow of funds and resource allocations, even if it's a small amount. That's not always possible, but when it is, it can make life a little bit easier. Using the harmonization of purchasing functions to balance what should be consistent and harmonized versus what still needs to be flexible, and allow for local level input, and especially getting to the provider level autonomy. Having consistent rules can smooth some of, if you can't bring everything together in one pool, you can create a harmonized funds flow with public financial management rules, with provider payment rules, and all of that. Also balancing with the provider autonomy, having the right amount of autonomy and accountability, which of course requires constant building of capacity and unlocking other obstacles to effective resource allocation, which might go beyond the fragmentation agenda. So thank you all so much for this great discussion. I'm going to hand it back to Kara to moderate the Q&A. Thank you.
Thank you very much, Cheryl. Thank you very much, panelists. That was an excellent, excellent set of country examples and some fabulous insights there. So I'm going to now turn to Q&A. I'm going to pick a few questions I can distribute around the speakers. I'm going to start at the bottom. This is a question from Martine, and it speaks to this issue that Cheryl just mentioned about change is easier when funds are additional. But the money that you got for the RBF funds, it was additional, but it was very modest. So why was it so powerful?
Thanks, Kara. Well, because, for example, it represents 100% of the fresh funds that all public health facilities at primary health care have. Because it was linked to results. Because the provinces were engaged since the very beginning in the design, and the national government was able to sustain a close dialogue with all provinces, providing additional support for those provinces that are more vulnerable or face greater challenges. That was very important to create a sort of cooperative relationship between different levels of governments. And because provinces as well as facilities have autonomy to adapt these national proposals to the local reality, to a very diverse country. So I would say that this combination of incentives, well-designed incentives, core but few rules, well-designed, the national government makes decision on key pillars of a health system, the benefit package, but gives space to provinces to make recommendation. The federal government decides the introduction of new output-based payment mechanisms in order to reinforce the incentives to health facilities. The national government decided to ensure and to audit provider autonomy, because that was the way to confirm that we were incentivizing health facilities that are the key player to improve effective coverage. So all these elements combined in a coherent way and in a sustainable way along 20 years make it possible to achieve great outcomes with very small levers.
Thanks, Martin. So that idea that the details of the design really matter, and those features of how the design is often have to do with the balancing of the inputs of different stakeholders as well, and making sure that things are flexible and adapted to local context. So the design almost matters more than the amount of funding. You can do an awful lot with a very small increment of funding as long as it is deployed in this really powerful way. So Gamini, there's a couple of questions for you. I'd like to start with this question about managing development partners. So kind of picking up on the question from Raul about you've got a multi-partner fund in the health sector, this direct facility funding fund, and yet, so kind of how did you convince them to follow one conductor in the sense of agreeing to a single set of monitoring and evaluation indicators, a single set of procedures, or did you? So how did you deal with all these different interests in constructing that multi-partner fund?
Okay, thank you, Cara. I think the advantage for Tanzania, there is a structure that is letting the partners to have to self-manage. Like for the health, we have, so you have the donor partner group health, and this is the partners letting themselves together. And I'm sure through the discussion and also convincing each other, they have the same interests and they see themselves in that. But also the Ministry of Finance and also the Ministry of Health are always in contact with these partners. So if there are partners who have interest to come with Tanzania, the first discussion that will be is to convince them at least to go through the treasury system, to go through the budget system, and also to convince them to also join the Health Basket Fund. And initially, when it started, the early years of the swap process, of course, the partners were operating individually. But the sector-wide, the swap agenda, when it was introduced in Tanzania, that's when the government take the front seat to negotiate with the partners. But the important part is to be clear in terms of how the money is going to be used to deliver the services. And the system needs to make sure that it delivers also based to the donors' commitment, because they have their own set of indicators that they have to report back. So the system needs to be able to deliver on that as well. So the planning and budgeting systems that have been developed, inside it also there are reports that have been integrated within the system to fit the demands of the partners, but also the set of indicators and the monitoring framework that has been decided. It brings together the government, the Ministry of Health, the local government ministry, the Ministry of Finance, and the partners sit together and discuss. So I think the magic bullet is more on negotiation, open the room to sit together, agree on the aspects that really are helpful to both parts. So it's, at the end, it's a win-win situation. So there's no a force to go into that direction, because the experience is, we still also have a lot of the money that's going through the off-budget or through direct vertical programs, and the government is still in a constant negotiation with the partners that are flowing with that. So that's the secret behind this process.
That's actually useful. So it's useful about it that the problem is not entirely solved by this mechanism. There are still other funds that are running through their own chains. But that sort of that spirit of negotiation and compromise amongst the people in the room was a way of getting agreement. And ultimately the agreement to reduce the burden on government of running this scheme and to be able to deliver the most health benefits with the funds available. While you're there, Jean-Marie asked, were there any challenges with the level of financial management capacity at the facilities, and how was this addressed?
Mm-hmm. So that was the first concern that was raised with a lot of people when the idea of introducing direct facility financing started. But the good thing in Tanzania, we had also a long history in the education sector, because the funds in the primary schools and secondary schools were disbursed directly to the schools before it happened in the health sector. But also the experience with the user fee as well started in the mid-90s, and later the facilities were allowed to retain the funds. So that experience was there. And what was has remained during the formal introduction of the direct sales facility financing initiative in Tanzania was to standardize the modality of reporting. So the templates for reporting, templates for budgeting were standardized across all facilities. And then there was a development of these electronic systems, like we have the electronic system for financial management that was extended to the facility level. And the objective of having this system is to reduce the amount of time and also the level of knowledge, financial management knowledge that is required to the facility. So a lot was automated within these systems. And the facilities are just a simple task of entering few information into the system, and the financial reports are generated automatically from the system. But there was also massive investment in terms of capacity building on how to do a simple reporting, how to do a recording of the transaction. So we need to build that. But it's the money that's flowing to the primary healthcare is not like a huge pocket of money. It's just the resources that are used for operation. Salaries are still managed centrally. Huge capital investment is still managed centrally, but also there's a significant amount of drug budget that is being managed centrally. So it's just for operation money. The example that has always been given here is like managing a family, like a household spending. So it sometimes undermines the capacity of these frontline service providers to manage the resources, but the same people are managing the budget within the family. So it's just that simple pocket. And if they're sitting together, they can easily decide on how to manage. But the concern was more on the time spent on doing the accounting for that. So to address that, that's where the advantage of the electronic system, information systems comes in as well.
Thank you very much, committee. Becky, I'm going to turn to you. There's a couple of questions here that are kind of related. So I think probably certainly unlike Tanzania, where there's a lot of external funding going into the system, in Indonesia, some of your fragmentation is caused by multiple sources of government funding, some of which is coming through JKN, through the insurance scheme, and some of coming as direct transfers of budgets for PHC and preventive care that doesn't go through JKN. And this, in practice, this is a question from Laurel saying that it's quite hard for the providers to manage these different funding flows. And that's kind of domestic fragmentation. And I wondered if you have any plans in Indonesia to unify those flows for primary health care into a single pool.
Yeah. Yes, Cara, thank you for the question. But it's true that our primary healthcare systems receive multiple sources. Some of them they receive from capitation, from social health insurance, and then also non-capitation. And then there is a direct transfer from central, and there is also from the subnational level. So actually we have primary healthcare with self-autonomy. They can really consolidate all this funding into one, but I think it's only I think it's only about 50% of the total 10,000 government clinics. The other one is when they receive the money, they have to automatically send to the local treasurer. So that is will delay the services, because every time when they need the money to buy drugs, to buy supplies, they have to propose a budget and some bureaucracy, and sometimes they don't have any shortage of funds. And then we aware also that we do some assessment in the primary care, how many application exists in the primary health care. And we not acknowledge there is around more than 100 applications. And people who works in the primary health care is not only finance application, but also about the programs, application. So all the person who works in the primary health care in the puskesmas are overburdened with administrative things. So what we did is trying to streamline the utilization, as well as streamline the budget consolidation. So we are in the process now. Not yet. We're still discussing on the design, how we can streamline, integrated, consolidated the budget execution. Maybe that can be implemented. We are in the process of finalizing the design, and hopefully we can propose for the next budget planning. Hope for the best.
So part of the
Yes.
unfinished business then.
And yeah, it's part of the unfinished agenda. Thank you.
Okay, so now I've got a question that again sort of links across a couple of questions in the chat. So Bikesh asked a question about how can bureaucrats and technical experts manage political declarations about new health, very political things, often announced at election time, a new health protection scheme that tends to create more fragmentation. And this is a little bit related to Ellen Vanderpoel's question about the fact that these schemes often are, that when they're announced for political reasons, they often focus on hospital level care paid for through fee-for-service mechanisms, rather than starting with primary health care. And the starting first with primary health care was one of the messages of the Lancet Commission. But of course, many countries are seeing the hospital care as being more politically attractive as a target for insurance schemes. So two issues there. How do you manage the politicians when something is politically attractive but might cause further fragmentation? And the other is in the countries that, I guess, Gamini, I think you've seen kind of launches, well, you've seen lots of discussion, but expansion of health insurance. And Becky, with JKN, I wonder if you could also remind us whether primary healthcare was always there in the insurance system from the beginning, or whether it came in later. So Gamini first on managing politicians.
Thanks, Carol. That's a very challenging question to manage a politician as a politician. But I think, talking from the experience in Tanzania, the very important starting point is coming from the technical experts. Ideally, it's important to document whatever idea that's coming, to document very well what is the positive and the negative inside it. And the way the process in Tanzania is, although there might be these big political statements, the process of getting that, like the introduction of a new scheme into the system, that process is very complex, because it starts with the technical personnel, who might be within the ministry, or having a team of experts, but you have to go through a process of scrutinization within the government. There's a cabinet secretariat, which is full of experts. These are advising the ministers in terms of whatever idea is coming. There is interministerial technical committee. which is bringing together all the permanent secretaries also to scrutinize that process. So it is very difficult for an agenda that is not implementable to pass through all these channels to go to the cabinet for approval. When it goes to the cabinet, there's a lot that is happening in between. So it's the same as the process of introducing universal health insurance. It took a lot of time back and forth. It's because there are all those intermediate layers that you have to go to scrutinize the process. So to address that, it's important to have that process of engaging the technical personnel inside it. So it can be remained as a political, as an agenda that's spoken out, but sometimes the government is very careful to implement things that seem like are not going to be sustainable over time. But I think the other important aspect is to build the capacity of within the ministry, but also engaging some of these politicians. Because for us, we might talk about fragmentation, but to them, it's not seen as a fragmentation system. So we need to make sure that we are engaging on this technical discussion with the politicians, at least to build the understanding in terms of what are the dangers that are embedded within whatever you are proposing. And it has to be repeated every time. They'll come up with hard questions, but they have to get an understanding of this. So it's very important to engage with the parliamentarians to discuss these technical issues at the very beginning before they start to move to the decision level.
Thanks, committee. It actually reminds me also of a blog I saw last week about how can research and evidence support good policy making. We do have to, as researchers and technicians, think politically ourselves and think about, well, what's the political problem that our leaders are trying to solve? And do we have some technically sound solutions that can help them? So kind of almost reversing the questions. Becky, can you just remind us, was primary healthcare always in the scheme from the beginning as a benefit, or was it, did you start with hospitals and expand the benefit package to include PHC?
Yeah, prior to the universal health coverage, 2014, many people goes directly to the hospital because poor quality in the primary healthcare, and then starting universal JKN in 2014, we from the beginning already regulate a certain numbers of services has to be completed at the primary care first, because the design that we have in the JKN is a managed care. So we start with the primary care, and then they can refer to the upper level, which is hospitals, secondary and third hospital. Unfortunately, when we offer the comprehensive benefit, unfortunately, the medical capacity of the primary care was not the same across the countries. Java, who is the biggest island and most populated, 60% of the population live in Java Island, are very fortunate because we have we have doctors, we have drugs, we have medical capabilities, mostly more advanced in Java compared to the others. So this is one of our challenges, is to ensure that the distribution and the capacity of the primary care across the countries are well equipped, and this is part of our reforms. So to answer your questions, is actually from the beginning, we are starting with the primary care, but previously the primary care quality is quite poor, so they just skip. But now it's getting better. We start by correct or do some infrastructures nicely, and then ensure that the medical capabilities is there, doctors and the business hours, and that kind of the drugs and everything. So hopefully that will change. That is why when we look at from the national health account, the spending of the JKN was reduced first from 18% to become only 13% in 2023. So we thought that we have to strengthen in primary care, because we know it's much more efficient when we empower the primary care. Thank you.
Thanks, Becky. And a really important reminder again that that financing alone does not solve problems of health system access and performance, right? The supply side needs to be ready to absorb the demand that arises when you do have these financing reforms, even if the financing reforms are about reducing fragmentation. There's a question here floating around, which is kind of interesting, which is fragmentation always bad? So I might just ask Martine to answer that, and then Cheryl as well, just to think about, we are suggesting that fragmentation is per se a bad thing. Is it fragmentation that's the problem, or is it something else that's the problem? Martine, you first.
Oh, yes. Well, one reflection is that perhaps our ministries of health are not well organized, or still today we don't have within our ministries of health sufficient capacity, sufficient managerial muscle in order to drive the health system that is very complex, messy, and it takes time to create a system to integrate actions and resources and investments among many different key players and actors. So in my experience, working with Argentina and several other countries, I think that our ministries of health in some way suffers from the existence of organizational silos. Then we can distinguish these silos at the care level system. So we have too many vertical programs with multiple and disconnected agendas. But we can explain these organizational silos or this fragmentation at the care model because perhaps we have functional limbos. There are core functions that, like the purchasing function, like the prioritization or planning function, the data governance functions that are not created, that they don't have sufficient resources, they don't have sufficient competent managers, they are not well defined. So in some way, this limits the capacity of the stewardship institution or of the health system or of the health network to integrate actions to provide better services with a long-term vision, with continuity, and with the preventive scope. So that's one reflection. We need to strengthen the integration capacity to reduce this cross-programmatic fragmentation at the central level, at the stewardship institutions, if we want to continue improving the, let's say, the effective of these financing mechanisms to strengthen PHC.
Thanks very much, Martine. Cheryl, thoughts on, is it fragmentation or is it lack of coordination is really the fundamental problem?
I think that's an important point in how we defined fragmentation in the paper, right? It's the different functions or different institutions without the coordination. So I think that's a very important part of the definition. And some of the arguments that you hear for fragmentation or for protecting a flow of resources or an institutional arrangement it is to make sure that you get those particular outcomes. And I worry that if these resources or responsibilities are dispersed, that the outcomes won't happen. And I think that might be the case in the short term. And we saw this, surely in the, early days of HIV/AIDS epidemic, like having very dedicated structures and resources got particular achievements. But you always run up against, in primary healthcare, always run up against the need to have cross-cutting supports and structures and services. So I think if we think about diversification and separation of functions, there is always an argument for having different actors and possibly even different resource streams. It's how they come together and the coordination. And we heard so many excellent examples of that today, and really excellent examples of how you can coordinate, even if you're not merging and consolidating functions and institutions and funding streams. And I think that goes to the question that we haven't quite answered yet, that came up a few times about in the cases where health insurance schemes are popping up dedicated to hospital services, and should the primary healthcare funding be moved into that? I think that's a very live question. And maybe we can pose it differently rather than answering it, but posing it as two questions. Should primary healthcare financing and curative care, tertiary care, all of that live together? Yes or no? And if they should live together, where? And these are two different questions. And I think, Ibubek, you made a very good case for why they should live together. So we can look strategically and holistically and know how much is going to primary healthcare and act on that allocation. Where they should live, it depends on a lot of things. Where can you purchase most effectively? Where can you get all these benefits that we're talking about? Which institutional arrangements in your country can get those benefits?
Thank you, Cheryl. So that seems like a good moment to end this part of our session. So I'd like to just thank all of our speakers again, Ibubek and Martin and Gamini and Cheryl for facilitating that discussion so beautifully, and to all of you who contributed your questions and observations and insights. It's been a really active conversation in the chat and the Q&A, and really, really stimulating. So thank you very much. And I will now just introduce the last bit of the session, which is some concluding thoughts from Susan Sparks. So Susan is a health economist in the health financing team at WHO in Geneva. So Susan, over to you.
Thanks, Kara, and thanks, everyone. I think it's been, as expected, a really dynamic and interesting session. And so a huge thanks to all. And I also just want to reflect a bit on when we came together to develop this paper as a team. It was really built on an idea of addressing or talking about the issue of fragmentation, but really wanting to have the practical examples and what it takes and first of all, what it means, this idea of fragmentation, and how it can work against some of the primary healthcare related objectives and service delivery objectives, but also how to begin to address that. And I think, as you can see from the colleagues, that it is this stepwise iterative process. And so I think what I wanted to reflect on is, and I'm spending a lot of time in terms of this impact of the current health financing situation, the reductions in external aid. I'm attending the Global Fund Board meeting this week, so today. And I think what we're hearing actually is, very interestingly, integration is the word of the day. And so you're hearing it across the board that the answer to the current reductions in external aid is, well, we just need to integrate everything. We need to integrate into primary healthcare. And it's like this counterfactual where we swing from one side to the other. And I think what we're hearing actually, and the word that I would like to introduce into all of this discussion, is really coherence. And what you're hearing is the coherence, and whether you're hearing about coherence in Indonesia around schemes, or in Argentina around provincial financing and prioritization, or in Tanzania around providers and facilities. And so it's not this either or, but it's really, how does that system work together coherently to deliver services, to prioritize population services, to have that efficiency. And so as we kind of all move forward as a global health community, and also all the people working really hard in countries to manage this situation and future situations, it really is that word keeps coming up in my mind. And I also really want to highlight the one speaker from the authorship team that wasn't able to join us today, Pierre Yamiogo, and the case of Burkina Faso, because I think it's a really important one in this context, because it's a context where the Burkina Faso really pushed to have World Bank funds integrated and incorporated within an existing scheme, within Gratuité, to be able to expand that and to use an existing scheme. And so I think this really brings together both the coherence on the purchasing functions and the importance of that interface between payment and provision, but also what can be done practically that it isn't impossible to bring these donor funds into a domestic financing system as well. And so as we move forward, I think, and in the paper, we also reflect on the need for more research and information on this topic. I think this is a practice paper. We've put that forward because we have the practical examples. We have the all of the motivation that came from the PHC Financing Commission, as well as a lot of other streams of work that we've all been trying to move forward. But really that we talk about the effects of fragmentation and needing to understand that more, but also on the root causes question. And I think it was touched on kind of tangentially a bit, is that this question of why do we continue to see, whether it's donor funds or political initiatives that work around the public financial management, work around the budgeting systems. And so this is an ongoing agenda around what's that core that's maybe driving some of this fragmentation, in particular in this moment, as we know there's going to be a lot of focus on domestic financing systems. How do we address that core issue so we can have that coherence? And so as we bring in and we talk about integrated services, what does it mean in terms of that core public financial management system to create that coherence? And who are the players that need to be at the table? And I think it was quite remarkable in terms of, it's clear the colleagues that have been working on this for years in these countries, right? This is not a one-off process. This is a long process, but the number of stakeholders and the engagement and the importance of bringing in, whether it's the provincial voice in Argentina or having the community voice in Tanzania, or really engaging with the parliamentarians and the Ministry of Finance in Indonesia, and how that work, it's not just the hard work on the technical side, but it's the hard work on the stakeholder engagement and bringing in those voices and understanding the root causes aren't just about potentially weaknesses in the system, but it could also be differentiated incentives. And so how we manage that as we really work towards this coherence in coverage, in outcomes, and moving forward. And so really looking forward to continuing the conversation and having more practical examples and research and really work in this area as we continue to move forward together. So back to Kara, and thanks to all, and really and thanks to Nouria and Valerie and Bruno as well for all the organization behind the webinar.
Thank you very much, Susan. And just you to note, at our peak, we were well over 450 participants. So this is a fantastic community in which to be having these discussions. And I love the idea of coherence as being our waymark moving forward. How can we really contribute to more coherent health systems in a context where there's a lot of uncertainty, a lot of change, but also a lot of potential to improve the use of money and to improve the delivery of services through having that focus on coherence. So with that, I will hand over to Nouria.
Thank you so much, Kara, for being such a wonderful chair. Thank you, everyone, for joining us today. And thanks again to all the panelists and to the chair.